Most people who work in that industry would say, yeah, you just need to strip everything down and start from the beginning.
Value-based care is where it really kind of rises from the ashes, and it's not about tinkering around the edges, it's about building something new.
How do you see health centers playing a role in value-based care now and in the future? Healthcare in America isn't easy. It's complex, it's political, and too often it doesn't serve the people who need it most. But there's one place where healthcare still works the way it should, where common sense meets compassion, and that's community health centers. Hi, I'm Amanda Pierce-Kelly. I'm the CEO of Advocates for Community Health, and this is Community Health Centers Unfiltered. This podcast is about what really happens at the intersection of policy, politics, and people. It's about the providers delivering care close to home, in small towns, big cities, and everything in between. It's about what community health centers do every day to keep America healthy, and what they need to keep doing it. Here, we go beyond the headlines. We unpack what's happening in Congress, what's keeping health center leaders up at night, and what's giving advocates hope. We'll talk about funding uncertainty, workforce shortages, and the legislation that could change everything. You'll also hear stories from patients, providers, and policy leaders about what's working, what's not, and what's worth fighting for. You'll hear from policy experts, community health advocates, public health leaders, and the people who built and rely on the healthcare safety net. Because this isn't just about programs, it's about people. It's about strong, self-reliant communities, and it's about making sure every American has basic access to basic high-quality care without politics getting in the way. If you care about practical solutions, real stories, and what's next for America's healthcare safety net, you're in the right place. Hi everyone, I'm Amanda Pierce-Kelly. I'm the CEO of Advocates for Community Health, and I'm so excited for the conversation that we're having today with Dr. DaShawn Groves, who is an absolute rock star and a former colleague and a dear friend, but who has been in the space, and I'm going to have him introduce himself, both in health centers, but I think more importantly in Medicaid and value-based care and public health for decades at this point, which is wild. But DaShawn, can you introduce yourself for everybody?
Yeah, sure. Hi, everyone. I am DaShawn Groves. I am currently serving as the Department of Vermont Health Access Commissioner up here in Vermont, serving over about 160,000 Medicaid members. And so I am really excited to be here and talking about one of my favorite topics. So glad to be here.
I mean, is that health centers or value-based care?
Both? Can it be both? Can I say it's two of my favorite subjects?
Yes, I appreciate the clarifier. But I am really excited in particular to talk about both, but I think value-based care, because in the health center space, it's really important. And it's been important for quite a long time, but I think it is rising in importance, especially in the environment that we're in. But just to get us started, because I think everybody's familiarity with value-based care is different, and I myself will say that for as many years as I've been doing this, I still feel like there are conversations as it relates to value-based care where I just sort of lean back and I'm like, oh, I thought I understood this, but I don't know if I do. So can you just give us some 101 and help people to understand value-based care and why it matters?
Yeah, sure. That's often the question is everyone comes in with a different kind of level set. And for decades now, healthcare has been paid in a way that doesn't make sense, right? It's like taking your car to a mechanic who charges you for every single part and every single minute of labor. And so even if the car breaks down, next week, you still have to pay, you have to go back and still have to do the same thing. And so the system rewards the fixes, not the outcomes. So not having the car stay on the road. And so that's really what value-based care is. It kind of flips side dynamic, and it's paying the mechanic now, or the doctor and if we're talking medical terms, to actually keeping you running as smoothly as possible over time. And it's just isn't about the visits or the repairs. It's keeping you healthy, safe, and kind of moving forward. The thing is, I would say that the thing about it in bigger picture terms, our current system is kind of like a house that's been patched over and repatched several times, and the foundation is really crumbling. We have policies here, a rate tweak there, and every patch kind of just covers up the decay of the system, right? And so the only way forward is kind of rethink the things that we're doing. And I know that sounds a little harsh, But if you look around, we're dealing with things such as provider burnout, health inequities, unsustainable costs. And these kind of things, if we're using the house metaphor, is all these small leaks in your roof. And there's signs that the structure is starting to fail. And so value-based care is where it really kind of rises from the ashes. And it's not about tinkering around the edges. It's about building something new, a system that pays for health outcomes, not volume, a system designed for sustainability and equity. And so the transition from kind of this paying for fee-for-service or all these little parts to a more of an outcome base is a little messy right now. So changes. But I think for the longer haul, it gives us permission to kind of reimagine a system that actually works for the patients, the providers, and the communities that they live in. And so that's kind of the reason why value-based care matters, is because the old way needs to kind of be burned down in a way. And healthcare can finally be reimagined in a way that actually works for the people that it's meant to.
So it's interesting listening to you. First of all, I really appreciate the metaphors because I think it makes it so much easier for someone who doesn't work in health policy and even for people who do work in health policy to sort of imagine it in that way. But one thing I was going to mention is that it also interestingly aligns with this moment in time in terms of, I think, the healthcare transformation that's happening. And obviously there's a storm underway and we're all navigating that. But I think about things like Make America Healthy Again and sort of a shift towards or leaning into primary care, chronic disease management, all of these things. But to your point, the whole point is to have this continuum to keep people healthy, to manage those chronic illnesses so that you're not having these catastrophic issues and the patchwork and all of that. And then I think the other thing with a lot of the change that's going on right now in general, it's hard. Change is hard. It can be very hard. But I think it's interesting because when I think about a lot of different elements of government and government programs over the course of years, it's just what you said. I think of the wallpaper analogy where it's they just kept putting, layers and layers and layers of wallpaper on top of each other. And, when you first do it, it's wow, it's beautiful and the room looks so stunning. But then when you just keep putting layers and layers, eventually they start to erode and the corners come down and, it just is messy. And really what you need to do, most people who work in that industry would say, yeah, you just need to strip everything down and start from the beginning, have a new clean foundation. And so I'm not sure we're going to have an entirely clean slate to start from, but what does excite me is the idea that we are moving in the direction of designing something that can be truly new and innovative and I think to your point, to serve the needs and the positive outcomes for all of the people involved, patients, providers, all the stakeholders. And that brings me to my next question, which is, how do you see health centers playing a role in value-based care now and in the future? Because they're obviously, and maybe it's worth taking a minute to pull out the fact that every health center is in a different place in the journey of value-based care. I think some of them are very far along and quite sophisticated, and then others are really early in the journey and maybe just scratching the surface. But I think that there are realities for health centers, whether it be their ability to take on risk, their dependence on or the need around PPS, all of these things. And I know you know all of it because you've been on all sides of it. So can you unpack that?
Yeah, I mean, if you think about it, the concept of a health center is kind of really at the heart of value-based care, right? Even if we don't call it that, we can call it whole person care, patient-centric. But in a health center, you have primary care, behavioral health, dental care, all those kind of wraparound services too. So food, housing, transportation. And also, for many people, especially those living in rural areas or communities that have really been left behind, health centers are kind of the most trusted entry point into the health system, right? And so they serve anyone who walks through that door, regardless of the ability to pay. And that, in its entire, that's the concept of value-based care. It's putting the patient there and surrounding them with the care that they need and paying them a little bit differently than that. So I really think health centers are kind of the backbone of the community health, the ecosystem, right? They're the place that can like really link hospitals, specialists, schools, food patients, housing support, all the things that a patient needs into one place and to help shape the health outcomes. I think it's about, you're right, that some health centers are a lot farther along. I mean, I think that goes with all providers, right? But having the right investments in terms of like data and workforce, that can also lead to ways of like measuring what really matters. I don't think it's about cost savings, but it's about really the patient experience and building out that trust. So if we go back to like the house metaphor, right? What we're trying to build, like the health centers are that foundation. They keep the whole structure ready and rooted in the community in which like the system should be built in. And the thing is, we just need to build out the rest of it. And that may be the last that I use the housing metaphor because I am not good with construction.
I mean, you seem like you're doing all right. I'm going there. I follow. So then let's talk a little bit about what it looks like to be the commissioner and sort of what the biggest issues are in terms of what you're thinking about when it comes to value-based care and implementation. And I guess to kind of put a finer point on it, what does it look like for patients and for providers? Because I think that's the other thing I think that gets lost in the conversation with value-based care is that much of the time, the conversation is focused on the provider because they're the ones that are needing to leverage the resources that are coming in as a result of the services they're providing. But it doesn't necessarily always connect, or at least I think in general conversations, like the role of the patient in all of this gets lost or at least overlooked. So, but as commissioner and in terms of like implementing these things, what does it look like?
Yeah, so I'm glad one of the things I do think about is the patient experience. And you're right, like the provider has the bigger voice when it comes to interacting with a Medicaid agency or a payer, right? Like the insurance not going to go out and find members. Or they should, because I feel like that's a different perspective that they're not hearing. But I do think there are kind of these three issues that I think about. And in no particular order, this is how I'm coming out with it. It's really infrastructure. So things need to be built around data, coordination, teamwork. And so as we mentioned earlier, like not all providers are at the same starting point, right? And so we have to think about that when we're building out these value-based payments is how do you create a glide path for providers who may still need IT platforms or different workflows or workforce issues. And so we really need them to kind of succeed. And so those are like the workforce and the data systems, those are all the things that are kind of the building blocks that kind of let the providers share to work as a team, like, right? Like if we're going back to health centers, like you would need data to share with a health center from a health center to a hospital and vice versa. And if you don't have the data systems that talk to one another, that's a huge barrier. And so it's something that we have to continually kind of think about as we move forward is that what is that glide path for where each person, what each provider and provider type looks like. The second is really about sustainability. So are we developing a payment system or a system in general that is sustainable? Like, as we said earlier, change takes time. Trust is really fragile, especially these days. And so providers aren't able to do kind of like overhaul the entire care that they need. And so I feel like that's where value-based care is getting stuck. It's like, how do we move forward and make things that are scalable more sustainable? So like thinking about the scalability piece of it. And then third, and I will harp on this, is because I am a huge advocate about putting the member first and thinking about that. Because at the end of the day, patients don't care what you call the model. They don't care if it's an accountable care organization. They don't care if it's a population-based or a pay-for-performance. right? They care about whether they get into an appointment that they needed and whether the doctors talk to them in a manner that they understand.
Yep.
And so so you really have to put that patient first and come out. And what I'd like to do is, like, when we're thinking about new models, is to say, let's think about the member journey here. If we're doing it this way, what does that patient need from that provider? And what are the pieces that are missing that will help that provider better serve that patient? Those are kind of like the things that I think about. I'm sure I think about a lot more when I get into the weeds of value-based care, but kind of those are the three things that I continue to kind of think about. I mean, there is a fourth one: is, do I have a budget to do this? Because some of these things they're not easy, right? Like, it's not easy to pay for data systems. It's not easy to have an appropriate and adequate reimbursement model, especially in these times when we're seeing kind of funds kind of evaporate. And so it's kind of hard to kind of think about that sustainability piece when there's all these other factors moving forward.
So that is a good segue for my next question, but I also want to stick a pin in the comment I made about the reality for health centers in terms of their ability to take on risk, and what ideas you might have in terms of, like, how do we tackle that, But before we go back to that, there's obviously major changes, federal funding changes on the horizon, and one of the things that we're wondering about is, what should states and providers be prepared for to keep the value-based care models strong and the patient experience positive? So I think it gets at some of the things you just said, to be honest with you. I think you kind of touched on it, but I think in light of what's happening right now, can you just lean into that a little bit more in terms of what do we need to do?
Yeah, I mean, if we think about it, right, we've been asked to kind of like do more with less, or kind of maybe there'll be an infusion of funds here and there. But I feel like we're now at a point of where we're being asked to do, like, we're not going to get anything else, but we're going to be asked to do more, but we can't do more, right? And so I feel like there's this kind of tension that's being built where we really have to start to think about that accountability piece. Like, we know that the funds are going to be tied more directly to measures. We know that there's going to be financial pressures. Resources are really tight. We know that there are workforce kind of costs that are going up. There's a lot of dependency now on, like, travel nurses, which you see kind of skyrocket, like, budgets right now, especially for health centers and the hospitals. And I think what we have to do is really look and prepare kind of for leaner times, but look within ourselves on kind of looking for efficiencies. And when I say that, I'm thinking about, how do we really kind of partner with other people in the community, right? So, and this kind of gets back to the role that health centers can play is, right, look at those I'm stumbling here, but look at those operations and what can be shared, what kind of, like, HR, finance, what other kind of shared services can we kind of combine, like, tackle together that would create some efficiencies? And so I think there's a lot of focus right now on, like, cost and savings, but there's this delicate balance of, like, preserving patient access and looking at their satisfaction. And I think that's really what states can do, like, really encourage partnerships, look at different types of integrative models that they can promote, look at even, like, not within, like, the state healthcare, like, think about it like social services too. But really kind of signal that the models here are here for the long haul, and that the next year they're not going to be up. Because the one thing that providers and patients need is that piece of predictability. Yeah. And so that's what has to be communicated, is that we're going to make these changes, but we're not going to sweep the rug out from underneath of you and abandon the new payment structure. Like, we have to give it time to kind of grow. In some ways, it's kind of like nurturing a baby, right? Like, it's here, we have to figure, like, we have to let it, there's going to take time in this kind of to mature. And so we can't just say, oh, budgets are tight now, we're going to take this payment structure away from you and go back to the old way.
Yeah.
Because that's not what providers need. They need to know that is going to be, that they can make those changes, whether it's in team-based care, EHRs, and that those investments aren't going to be taken away or be shouldered on their behalf.
So let's go back to risk then, because I think this gets at that, because I would wager to say that there are a number of health centers who, like I said, some that are further along on the path, others that are not. But I think pretty much all of them would like to be further along, but it has to do with like how much risk they can actually take on. And I think the question I have is twofold. One, sort of with your knowledge of health centers and sort of what that looks like, words of wisdom as it relates to that in this moment. But then I also think in your present role, is there an opportunity there? Like how, obviously ACH is having conversations with CMMI constantly about, and CMS about how do we construct models that are health center specific to sort of address some of these things. But I think in the seat that you're in right now, like, what are your thoughts and what does that look like? And then I think connecting that to, because I know you have lots of ideas, what are some of the innovations that you would call out? Because I think now's the time, to your point, like a lot of things are changing, but I think there's opportunities, and in particular, the innovation component of this is going to be really important.
Yeah, I mean, so the part about risk, right? Like, we have seen health centers participate in risk models. Like, it's possible. Like, we've done patient-centered medical homes, accountable care organizations that both have that, like, both sides of the risk, right? Like shared savings, but I think what gets in the way in terms of like the folks in Medicaid is the PPS structure, and thinking about that's you can't do anything with it, right? And so a lot of people are like, we'll just walk away, but there's so much in opportunities in terms of the alternative payment methodology. And realizing that the PPS is the floor, but you can build in that risk corridor, right? Like, as we talked about, like, part of it is making sure that the health centers or the providers have that appropriate and adequate payment, right? That we're paying for the things that we should be paying for and taking care of their costs, but also having that kind of flexibility in terms of saying you can do more with this money if you can achieve some sort of savings, right? Like, you can recoup those savings. So I think that's the bigger piece, is like there's a lack of understanding of how PPS and the APM can work together, right? And sometimes what I hear a lot of is, oh, the APM is like the icing on the cake, we're already paying. But if you think about it, the PPS hasn't really been like factored in since like the early 2000s, right? Maybe there's that inflation structure, so like it's not true cost base. It's cost based in a way, but like you're able to take risk in an APM, but the thing is that you have to make sure that you're able to take risk, and like those are the things. Like, do you have the data systems in place? Do you have the providers? Do you have like the appropriate kind of the team to kind of do outreach and eligibility and to wrap around those services? And so risk is possible, and we've seen it done in health centers, and they have done it extremely well. And even like looking at like the different outcomes that they've had, like they are a key piece of taking risks. Like, if I were a betting man, health centers would be like, I would want them as a partner in a risk-based model, because I know that they would be able to kind of generate savings, and they do generate savings. So to get at your other question is what kind of like innovations that we've seen, right? I think what we are starting to see is a lot of health centers partner together to form clinically integrated networks, right? So that is about coming together, thinking about your different populations, but like under the umbrella of we are going to do evidence-based clinical measures and do it in the same way despite the different populations, right? Like we're going to make adjustments, but we're going to come together, we're going to share data, we're going to do we're going to share resources and really kind of like build upon that. And being able to take that integrated network and say, if I'm doing this for a payer X, let's pursue some sort of risk model. And you have seen it. It's been done in DC, right? Like they have a clinically integrated network, and they have worked with a Medicaid MCO and have done a shared saving, like a value-based payment. And it's like one of the kind too. So I applaud, not only have I known about it, but like I applaud them for getting that far because I've seen how much work it has taken them, because it's not easy to take a group, like each individual health, you see one health center, you see one health center, right? It's like saying you've seen one Medicaid program, you've seen one Medicaid program, right? Like you've seen one health center, you've seen one health center. And so each of them are different. And to be able to come in under that kind of structure kind of allows that kind of improved workflows and operations that are able to kind of generate savings that a payer would want to see.
That makes sense. So I have more questions for you, but before we go on to the next question, you've spurred something in my mind because you've been on both sides of it, which I so appreciate. We love you for that. But what do you think the biggest maybe like misperception or misnomer is on the Medicaid or like the state policy side about health centers? Like I'm just trying to think of like, because they know, I don't want to say they, but in general, I do feel quite confident that, you know, most folks that are running Medicaid at the state level or county or whatever, like there is a decent understanding of health centers. It's not that, but I do also think that there are still misperceptions or assumptions that are made maybe. Like I'm just curious, like have you found that in the position that you're in where you've found yourself in conversations where the understanding that maybe exists on that side of the table isn't quite exactly what it actually is for the health center, or am I making assumptions?
No, I mean, you're not making assumptions. And I think it goes both ways too. Like it's very interesting to have sat in both seats. Yeah. And to kind of know what's under the hood, like in both instances, and like, that actually isn't true. And no, that's not true either. I think from the Medicaid perspective, right, I think it's a harder sell. It's like people really don't understand the structure of the PPS, nor kind of where to go with an APM structure. And so I think that's the hard sell. It's like, how do you do it in a way that an APM promotes outcomes, but also from a state perspective, yeah. I also need to make sure that I'm not inflating my budget too, right? So I'm working within a zero-sum game here, unless there's money falling out of trees, and we know that that's not the case anymore. But it's really that understanding. It's like all those kind of statutory kind of health center specific like payment requirements, the PPS, the change of scope, what's a Medicaid service, what's allowable cost, like that, it just mucks up the water so much. And it's interesting because sometimes when I first got to DC, there was a lot of explaining of what's a PPS, what's an APM, why are we doing it this way, or what's allowed, what's an unallowable, why you can't put like a cap on something. And so I think it's just about understanding like what it all means. But I do think the states see you all, like health centers, as a major provider, like a major kind of partner, right? And we may not all agree that everything is all copacetic, right? Like there are going to be times that we disagree. Like we can't always give more money, and that's because we don't have any money to give. And so I think from the other side, it's not that the states are kind of like hardballing you all. We're working in this tough environment of we still have balanced budgets, right? We can't increase costs. If we increase costs, that's likely a reduction somewhere else in the Medicaid system that's hard to kind of balance. And so I think the other thing too is we see health centers, but we also know that there are other payers, right, that you all can lean on, leverage as well, right? Like the commercial side of things. So like there are opportunities to say, hey, I mean, there was one instance where a health center was like, or they said something, and I was like, but we're not even your biggest payer. Like, we're a third, we may be less than a third of your payer mix. I'm like, so you still have leverage elsewhere to kind of go to, right? And so that's one of the things that states look at too, is like, we know that sometimes we're your largest payer, like the part of your largest payer mix, and we will work with you on that. But there are other times when we're like, you need to work with your other payers too.
Yeah. No, I think it's a really good point. And I also appreciate you calling out that like it exists, the assumptions exist on both sides, or the misperceptions exist on both sides. I want to bring us back to patient care a little bit, and in particular call out, like, are there examples of, because before we even get there, I really appreciate, and I know this about you for all the years that I've had the pleasure of being your friend and your colleague and all the things, but I know you care about the patient, and I know that that's really central to the lens that you bring to your work. But in the context of value-based care, can you think of an example where you did see like improved outcomes, or like a really special scenario where patient care and patient experience was really positively impacted as a result?
Yeah, I mean, these are all kind of provider stories. So these are all kind of second-hand experiences. But I mean, what we're often told, right, is you think of a patient who has diabetes or a chronic condition, who is a frequent flyer to the ED, right? Multiple times a year, sometimes a month. But once they get into the door, or once they're starting to be engaged and shifted to a team-based model that has care coordination, that you're able to have an appointments on time, and that they're able to kind of have that structure in place, the patients not only get better control of their blood sugar, but they also get the things that may have been causing it, like other stressors, right? Like housing support, like a walking group. Like there are things there that, because we've moved to not a pure kind of encounter-based approach, but more of a kind of like, I want to pay you this lump sum and you're going to take care of DaShawn. And that allows the health center to kind of like think differently and be like, okay, now that I have you, here's all the things that you need. DaShawn, what do you want to tackle first? And so you kind of start to see that care system develop and envelop that patient, and where you see they don't rely on the ER visits because they've established a kind of a trusted partnership with their provider, and they feel seen. And so like that is kind of like the direction that that is like one of the examples that I have seen and kind of love to hear. Like those are the feel good, oh, this is actually like what we're doing is actually working.
Do you feel like it seems as though at times that healthcare is reverting back in some ways? I mean, it predates our existence, but when I think about healthcare in the first half of the last century, where it was home visits and it was much more, you're looking across a lot of different elements, not just medical or not just, the sort of traditional clinical space. And it seems like it's going back in that direction somewhat by necessity, but I also think like largely because of the conversation around value-based care. But I also, something that I hear, and it differs from health center to health center, but, for a variety of reasons, there's a cultural shift sometimes that I think has to happen when it comes to value-based care, and some of that when it comes to providers, it's like, wait, how many people do I have to see a day? I'm doing what, and now you want me to do what? So can you speak to that a little bit in terms of just when it comes to providers, sort of what hinders their sort of willingness, or what incents them? I mean, I think we know what incents them. It's greater resources, et cetera. But I think that's another piece of this that is not necessarily overlooked, but I think maybe gets lost a little bit in the conversation.
Yeah, I mean, I do think that the pendulum kind of swings back and forth a little bit, right? Like we were all into like home visitations like early on, and then the system for whatever reason decided we're going to pay for you to come into the office, and like especially during the pandemic, right? Like we're like, actually we have telehealth, and then after the like post pandemic, it was like actually we're going to take back those telehealth visits. So it's really fascinating to kind of see where the system like places their investments. But in terms of like what helps or hinders a provider, I think it's really like, we'll talk about like first in terms of hindrance, I think administrative burden, right? Like you hear providers harp about documentation in EHR, like enrolling in Medicaid multiple times because you're at one health center for part of the week, but you're at another health center for the other half. And so like you have to be credentialed twice, and that takes time. I think the financial risk piece, the uncertainty of that risk, without knowing kind of the support system that you have, or without knowing kind of like what you would need in order to take on that risk, is kind of a hindrance. I mean, it's just, there's a lot of uncertainty about whether models will last or whether it's a short-term pilot, right? Like we have seen several kind of, like we have seen CMMI like pull several of their kind of big kind of like their models, and so like that creates some uncertainty for providers. And then other times when you're like, let's pilot it and test the scalability piece of it, and then you do all this work and you change your systems, and then the payer says, actually, we're not seeing the outcomes that we were expecting. We're going to move in a different direction, right? So that's kind of like what hinders providers. I think what helps them is the complete like it's the reverse, right? Duh, Amanda. It's really kind of having those clear, consistent expectations that what are they truly being held accountable for? What is the role of the payer or the issuer that really kind of like that defines those roles and responsibilities? It's about like really having a robust data sharing and technical support, making sure that you have actionable data, right? But like in a timely manner, and in a time that you need the data. Like the data can't be months old, and you're trying to see a patient that just hit the hospital ED, and you're trying to go see them, right? Like what good does that do? But I also think like having peer networks where providers can learn from each other and kind of like develop that support of here are the things and share ideas and kind of what's working, what's not working, those kind of best practices. I think that's where you start to see providers really kind of embrace the different types of models.
So I love that you just said that, because I think a lot of what ACH does is that it's the peer-to-peer space and sort of learning from each other and really lifting up some of the, best practices, if you will. I'm thinking about the time that we have, and I know you're very busy because you're a commissioner and you do lots of important things, but I think one of the things that is very top of mind, and I'd love to get your perspective about this, but just as it relates to HR1, like how do we, I know, don't roll your eyes. You knew this question was going to come up. So, but like what can and should we be doing? And obviously like the primary care associations are amazing and they're doing a lot of outreach and continue to maintain the relationships. But I think also like, what is it that health centers can and should be doing right now? I think everything from to prepare, but also I think to try to understand, communicate, help design, like everybody, like this is what's happening. And so I think at this point, people are now in a space where, one, we're still waiting for information. Obviously, guidance is coming, hopefully soon. And that will help. But I think there is in this space as well a lot of unpredictability. And I think there is also a great desire to try to make this as successful as possible in a variety of different ways. One, in the patient space, obviously, to make sure that there's as little disruption as possible. And so helping to create the systems and the procedures to keep, continuous access and hopefully continuous coverage. But then I also think for health centers specifically, obviously the financial implications of this are really significant. And so I know these are things that you guys are thinking about, but do you have recommendations in terms of what health centers can be doing and how to partner? I mean, I think how to make this successful.
Yeah, I was hoping I would escape an HR1 question, but it's, for some reason, it always comes up in every conversation. I think we have learned a lot from unwinding, right? And I think those lessons learned should be applied to what is about to come like at the end of, or at the beginning of what, 27? Yeah. 20. I get my dates wrong all the time with this. But I think for health centers, the role that you can play is to really, like, you are the ones who are really going to be the first line of defense for coverage, right? And to make sure that those patients have all the information, the paperwork, because what we know, right, is that it's not having a work or like education. It's about having that paperwork. Yeah. In place, so making sure that they have that, because that's not having the paperwork or not submitting it in time. Those are the things those are the reasons why people lose coverage, right? So being that first line of defense for Medicaid agencies and communicating the role that you all can play, right? Like be the assister, the outreach, the enrollment, the eligibility piece, the things that you have excelled at so much, right? Continue to do that. And to work with the states to make sure that that process works in a way that, one, the states can comply to with the feds, but like that the patient is able to make sure that they're there. And I think, so like really being that kind of that communication piece, right? Like getting the word out that changes are like people know changes are coming, but like they don't know when, they don't know what it looks like. And I hear that all the time. And like, I was like, actually, nothing's changing this year. It's actually next year that we have to start worrying. But like our planning starts this year. But starting to get the word out and being that trusted voice in the community where people can listen to and to kind of think through ideas of what happens if a patient doesn't have employment, or what are the opportunities, right? Like I was just spitballing the other day and I was like, well, could we just offer an internship program, right? And like that's how they get their 80 hours a week, or couldn't they do is there something there that providers or the community can kind of create to kind of help them meet those requirements, but also to document that they're actually participating. Yeah. And that is my biggest worry, is like the paperwork piece. Yeah. That administrative piece is what's going to kind of be the barrier. Not that, because when you look at the data, right, there's a lot of people who already meet those exemptions or already who are working. So I think one is to helping dispel that information that they're just at home, they're 26 years old, they're just on their parents' couch. But like helping them help us show that, document that they're actually meeting those requirements. Yeah. And so I think that's the big piece, is really lean into your outreach and enrollment and your eligibility piece.
So you are also not going to escape a question about the Rural Health Transformation Fund.
I like talking about that. That's fine.
But it also ties to the conversation, because I couldn't agree with you more. Like, I think there is an opportunity for health centers to document and to demonstrate, but also to your point, like to get ahead, to try. Obviously, we're waiting on guidance. And in some cases, like every state is going to design their own version of what this is going to look like. But as you know, the funding and resources scenario for health centers is quite precarious right now. And so the Rural Health Transformation Fund becomes really important. And so I would love to hear sort of just general thoughts and outlook on that, and sort of maybe what it looks like for you guys in Vermont. But then also, and this came up in a conversation I had just recently with Blair Bryant from NACO about, obviously you mentioned this earlier. You guys have limited budgets. Like everyone is dealing with limited resources. But is there also conversation about and recognition of the role that health centers play in terms of savings, and sort of like and then prioritizing where resources go in order to support that. Or, when we talk about outreach and enrollment, it's sort of like, okay, and health centers we've proven, are among the best, if not the best, to do that, but they need support and resources to do it. So again, thinking the two hats, because I know you've been on this side of it, that the role that health centers play, but also the realities of what it looks like to implement and where to allocate resources, and then specifically the fund. It's a lot of questions rolled into one.
That is a lot of questions. So I'm going to,
You're
in
a
the
doctor.
way that I remember
I know you can handle it.
In terms of the Rural Health Transformation Fund, I think that's a tremendous opportunity to really think about how do we design the healthcare system in the ways that fit into what we've seen the administration put out in their buckets, right? Workforce, IT, like sustainability, tying into making America healthy again, like all those initiatives, right? Like chronic disease. And so there's a tremendous opportunity there that, especially here in Vermont, while small, very rural, right? Yeah. And so kind of thinking about how do we start to address some of what I would say kind of like the shortages, the crises, and make those opportunity. In Vermont, we've been transforming for quite some time. And so how do we build off of those transformation efforts into making something that we're not we're not creating the wheel again, but we're building off of what the supports that we already had. In terms of the role that health centers play, yes, I think every health center should be a part of the transformation fund. It's just well documented that health centers are, one, they improve outcomes, they generate savings, right? But I think the story there is not everyone sees it, especially from a Medicaid perspective, right? We see the money that's going out the door. We don't think about, oh, you just saved us 1,000 ED visits because of that, right? So tying that back into here's what we can do, here's the role that we can play, here's the partnerships. And I think what it comes down to, right, it's really about the partnerships that we need to build upon. I think there needs to be, I feel like there's these silos, right, in healthcare, right? And the job of the transformation fund should be to break down those silos in that hospitals, health centers, mental health providers, long-term care providers are all working together because they're all serving the same population, right? And so really kind of thinking about what is the strengths that each partner brings to the table and building off of that. And I think that's a tremendous opportunity there. I feel like there was another question and I don't remember. So what did I miss?
I love where you landed, because it actually brings us to a really, honestly, from my perspective, a bright spot and some optimism. And I love that you recognize, I know I'm not surprised that you recognize the role that health centers play, but I think that your advice around tying it back to how it is going to yield savings and 1,000 ED visits that were avoided because health centers were able to, provide that continuous care. So I think that's not just food for thought, but really wise advice in terms of the conversations that are happening right now. But I also totally agree with you in terms of partnership. And again, we go back to our metaphors of the home and the wallpaper, and it's sort of here's where we're at, and we all have this opportunity to lean into redesigning in a way that is going to create the best possible scenario and outcomes for patients, for providers, and for all the stakeholders involved. And that's the present situation in terms of what's happening with HR1 and the transformation fund. But I also think it's value-based care to kind of bring it all the way full circle to that. But I'm just really, really grateful that we got to talk with you and that you are doing the exceptional job. Vermont's lucky to have you in the seat that you're in, because you are truly a rock star. Yeah. But I hope this isn't the last conversation we'll have on the podcast, because there's so many more things to talk about. In fact, I'd love to talk with you sometime as we get closer to truly rolling some of this stuff out, because there's a lot more information to come and guidance and design. So to be continued, my friend.
Yeah, definitely. I'm always here for friends. And an ally of the health centers. So
Always, always. Well, thank you a million times. And we are here to help if we can do that in any way. But we appreciate all your amazing work and your very exquisite brain around all of these very complex issues.
It's not that I have a great team that backs me up. So it's not just me.
Thank you, DaShawn. Talk to you soon.
All right. Thank you.
So that's a wrap on today's episode. Huge thanks to our guest, Dr. DaShawn Groves, for breaking down value-based care and the role that health centers play. The experiences and insights from different states, communities, and patients offers us important lessons on how to improve healthcare and get the highest quality care for all people, and from every precious healthcare dollar. If you're passionate about value-based care, I know there are many of us who are, and you want more information about affordable, efficient, and effective healthcare, you're in good company. Now is the time to speak up and push for smarter policies. We have resources on the website here at advocatesforcommunityhealth.org to help you get started and to support you along the way. Don't forget to subscribe, leave a review, and share this episode with your networks. I'm Amanda Pierce-Kelly. I'm so grateful that you joined us today for another episode of Community Health Centers Unfiltered. We'll see you next time.